Good afternoon, everyone. Welcome back to the class of Analysis of the Facial Beauty. I'm Dr. Strategy. Until the last session, we have talked about the very well established orthodontic self analysis, which to our dentist is very familiar with. Most of the measurements we have discussed are generally two types, the distance and the angle. These two parameters are quite easily understood because they are based on the basic Euclidean geometry and even can be thought as intuitive in a sense. However, it seems that there is something more for proper analysis of the facial aesthetics. Then, what will be the something? According to the Sir Harold Gillis, there are no straight lines in nature. Right. Even though we rely upon the distance and the angles for objective analysis of facial components, most of them, in fact, exist in nature in curved forms. So, to begin with, the facial curves and curvilinear relationship will be discussed first. And then a little about variation according to sex, ethnicity, and age. The importance of flowing curves to the appreciation of beauty in nature was suggested by the 14th century Persian poet-scholar Hafez of Shiraz. Such flowing curves were part of the beauty of geometry and were described as present throughout nature, but particularly important in the beautiful female face. The gentle waves in the hair, the curve of the eyebrow and eyelashes, the lips, chins, and so on. Straight line and sharp angles tended to diminish beauty, whether in geometry or the female facial form. The facial surface has a large number of points or surface and landmarks. These points may be defined in that they are visible to human eye but are not divisible into parts. For example, nasal, pronasal. Points or landmarks joined together continuously in a row form a line. A line may be defined in that its length may be divided into parts, but it is so slender that it cannot be divided in widths. Lines on the facial surface are almost never straight but tend to curve, hence may be termed facial contour lines. If many such contour lines are joined closely together, they will create a surface. Lines and surfaces may curve outwards, resembling the outside of a sphere. This is termed convexity. Conversely, they may curve inwards, resembling the inner surface of eggshells. This is termed concavity. The interrelation of these undulating facial peaks and troughs may be referred to as the facial curvilinear relationships. Facial contour lines are almost never straight, but are curvilinear in form. These lines curve to various extents over underlying dentoskeletal prominences and at the transition between various facial regions. The facial contour line angle may be described as having reduced angularity. The other terms are soft or feminine, blunt or smooth. Such contour line angularity is more common in the female facial form. On the other hand, there is an increased angularity. The other term of the increased angularity is hard, masculine, or sharp. Such contour line angularity is more common in the male facial form. Male faces tend to exhibit greater angularity, whereas female faces have reduced angularity and increased softness to facial outlines. Increased angularity of the facial curvilinear contour lines in women tends to diminish attractiveness. However, in terms of masculinity or femininity, the acuteness or obtuseness of the line angles is not as important as the smoothness of the transition between the lines. For example, an increased or obtuse gonial angle may be still appear masculine, If the transition between the posterior ramus plane and the inferior border of the mandible is sharp with increased angularity, conversely, a reduced or acute gonial angle may appear feminine if the transition is smooth rather than sharply angled. The evaluation of the lateral view of the face, termed facial profile, is highly significant in facial aesthetic analysis. This is particularly true of the curvilinear consideration of the soft tissue. Calvin S. Case, a physician and an orthodontist, described the importance of the facial profile curves in detail. He emphasizes the curvilinear form of the three specific regions. The first is a frontonasal curve. This is the uppermost curve of the facial profile, joining the nasal dorsum and radix to the glabella region. The form of this curve provides much of the characteristic of upper face. The next is a nasolabial curve. Below the nose, the upper lip should have a graceful concave curve from the base of the nasal columella to the border of the upper lip. The last is a labiomental or mentolabial curve. This forms the most inferior curve of the front of the face, giving character to the chin and forming a graceful arc from the chin to the border of the lower lip, with the mandible in the rest position and the facial soft tissue in repose. Peck and Peck refer to the attractive appearance of these facial profile curves as a profile flow, which may be visualized as a series of waves or reversed S's on the right profile. These curves are S-shaped when viewing the left facial profile and reverse S-shaped when viewing the right profile. They added irregularities or acute curves, though often tolerated, especially in males, tend to disrupt an otherwise harmonious profile. A nasal hump or very angular lips, for example, concentrated the observer's attention, much like a discolored anterior tooth focuses our attention away from the rest of the teeth. It is therefore incumbent on diagnosing clinicians to accurately evaluate the sinus curvilinear relationship of the facial profile. The next is the contour defect. The morphology of soft tissue contour of a number of facial parameters consists of series of curved lines. In addition, as already described, the transition between various facial parameters consists of smooth flowing or curvilinear forms. Interruptions in these curvilinear lines and surfaces are described as contour defects. For example, the brow nasal tip aesthetic contour line, which extends from the curves of the eyebrow to nasal tip, should be smooth, gently curving, and devoid of contour defects bilaterally. Fractures or deviations of nasal dorsums are visualized as nasal contour defect, which may be unattractive. When excessive and displeasing to the patient, the correction of such contour defects to conform to the smooth flowing aesthetic lines may be required. Sexual variation in facial appearance refer to the typical structural and morphological differences between male and female. An alternative term is the gender variation. However, the word gender and sex are typically used in slightly different ways. Gender tends to refer to social and cultural differences, whereas sex refers to biological differences. There is no one feature that distinguishes the male from the female face. It is an overall pattern that distinguishes the male and female face. In addition to some women may have rather masculine facial features, whereas some men have rather feminine features. The main differences in skull and facial morphology between males and females tend to occur during the pubertal growth spurt. The male and female faces grow more disparate at this time, and the distinction remains during the childbearing years, though similarities tend to increase again in older ages. Main differences between the male and female face are listed as follows. The first is size. Adult male tend to be larger than female due to faster rate of growth during puberty and a longer period of growth. Nevertheless, there is a considerable range of variation in both sexes. Overall shape. The female face tends to be more oval in shape, with the two rounded corners of the hairline coming down to the single point of the chin. The male face has a more square appearance, with the lateral aspect of the square-shaped forehead and M-shaped hairline continuing down to the wide, square gonal angles. The lower anterior face height is relatively greater in the male face, usually because of their relative greater upper lip height and increased chin height. The next is the cranium. The male cranium tends to have relatively thicker bone in the neurocranial vault, and male skull overall has more pronounced muscle origins and insertions. Hairline. The male hairline tends to have M shape as it often recedes laterally, just above the temples. Forehead inclination. The male forehead tends to slope posteriorly. The female forehead is usually more vertical. Brow ridge. The frontal sinuses are larger and the glabella region and superciliary arches are more pronounced in men. Man's eye thereby appear more deep set. The superior margin of the orbit is more angular and square-shaped. There is also a difference in eyebrow. Male eyebrows tend to be horizontal, straight, relatively thick, and positioned on or just inferior to the orbital rims. Female eyebrows are generally higher, just above the orbital rims, and are usually shaped as a gentle arc. Nose. The male nose is proportionally larger than the female nose. Women tend to have smaller noses with more concave dorsal morphology in profile view, whereas men's noses are relatively larger and more pronounced. Cheekbone. Female cheekbones are less prominent but may appear more prominent due to reduced projection of the surrounding areas. Lip morphology. Female vermilion exposure tends to be greater due to an increased proportion of vermilion height to overall lip height. Mandible. The male mandible is relatively larger with broader bigonial width. The gonial region is more angular. The ramus drops down relatively vertically from the ear region and turns anteriorly with a relatively pronounced gonial angle. The female jawline tends to have a gentle curve from ear region to the chin. Chin. In frontal view, the male chin is broader with a more square shape. Female chins tends to be round and narrow. In profile view, the male chin tends to be more pronounced due to greater prominence of the mandibular symphysis. The next topic we should discuss is the ethnic variation. The ideal facial proportions described by the classical sculptors were later refined by the Renaissance artists. However, modern proportional relationships employed in diagnosis and treatment planning are primarily based on the contemporary anthropometric and cephalometric studies undertaken mainly in the last few decades. The majority of available data stems from white Caucasian population of Northern European descent, though data on various ethnic groups are steadily becoming available. Nevertheless, ethnic differences should be taken into consideration when evaluating a patient for facial aesthetics and/or reconstructive surgery. The concept of racial groups within the human population dates back to the 19th century. The German physiologist and anatomist Johannes Friedrich Blumenbach, considered the founder of physical anthropology, developed a racial classification that grouped modern humans into five broad categories: Caucasian, Mongoloid, Malayan, Ethiopian, and American, based mainly on craniometric measurements. He introduced the term Caucasian or Caucasoid to include a broad group of people in Europe, Western Asia, and parts of the Indian subcontinent. In North Africa, Blumenbach believed that this Caucasian race originated in the Caucasus region, a mountain range lying between the Caspian Sea and the Black Sea. According to the Blumenbach, the term Caucasian included people whose skin color ranged from light, for example, in Northern Europe, to dark, for example, in parts of North Africa and India. The term Mongoloid related to the indigenous people of Eastern and Southern Eastern Asia and the Arctic region of North America. The classification of Blumenbach is outdated and the categories are no longer considered scientific. In fact, attempts to classify human racial type are today recognized as scientifically baseless. Evidence from the modern science of genetics has demonstrated that humanity was never divided into distinct lineage. Steve Johns, professor of the genetics at University College London, writes, "The genes do show that there are no separate groups within humanity." The British biologist Sir Julian Huxley suggested that the word race be replaced with an ethnic group. He wrote, "The word race, as applied scientifically to human grouping, has lost any sharpness of meaning. Today, it is hardly definable in scientific terms, except as an abstract concept." Variation in craniofacial morphology is present within and between populations. As with the human genotype, it has been demonstrated that variation in human cranial morphology is actually far greater within than between populations. Interestingly, the most marked difference in craniofacial morphology occur in Africa. However, some tendencies are evident when comparing average facial morphology from populations of different geographical origin. The science of genetics has put an end to the concept of race. This would suggest that such variation in facial morphology may be best termed geographical variation, suggesting indigenous geography, environment, and climate as the primary etiology of the facial variation between different populations that has occurred over time. Nonetheless, until this term is better accepted, such categories of facial morphology variability may be subcategorized as those ethnic groups. For examples, there are 56 known ethnic groups in China alone. Northern and Southern Chinese have distinct differences in their facial morphological feature. Northern and Eastern European are white Caucasians, but again with the marked different facial features and proportions. When planning treatment, the clinician must take into account the data when they are available for normative values and normal ranges of variation within each major ethnic groups. In addition, the clinician must not lose sight of the fact that there will be patients requesting features from a different ethnic group, possibly due to cultural influences with potential psychological implications. The greatest differences among and between ethnic groups seem to be in the dental-alveolar region. Therefore, it is useful to compare patients' craniofacial morphology to average for their nearest ethnic group. When craniofacial anthropometric and cephalometric data from a separate ethnic groups are not available, the data from the nearest ethnic group may be employed to provide guidelines for diagnosis and treatment planning. Clinicians must understand the characteristic features of different ethnic groups and appreciate ethnic variation in order to aim to create a natural appearance. Yet, it remains prudent for analysis and treatment planning to be individualized. In other words, each patient must be evaluated as an individual. It is notable that the term Oriental has been used in the past to refer to individuals of Far Eastern descent. In US English, Asian is the standard accepted term in modern use. In British English, where Asian tends to denote people from the Indian subcontinent, specific terms such as Chinese or Japanese or Korean are more likely to be employed. As a rule, it is far more accurate and clinically useful to refer to specific ethnic groups, particularly when normative data for that population are available. The next topic is the facial aging. The aging process is an inherent part of life. Relatively characteristic changes occur to the facial appearance in each decade of life, which makes individuals look their age. However, in some individuals, a number of factors may contribute to an acceleration of aging process. As such, an individual may appear older than their years. These factors may include excessive alcohol and tobacco consumption, chronic exposure to the sun, and prolonged illness and stress. An understanding of the aging process is important for two reasons. It permits the clinician's goal to help restore youthfulness feature termed facial rejuvenation, which correspond to the patient's chronological age, providing a natural appearance. It helps to prevent a clinical procedure that may lead to unaged appearance, particularly in relation to a patient's future appearance. For example, excessive intrusion of maxillary incisal teeth in a younger patient may lead to a reduced incisal exposure, particularly as the upper lip sags with age. Facial aging affects the soft tissue integument and the underlying dentoskeletal framework of the face and occurs as a result of several factors. Skin. Regarding skin, several processes related to aging affect the appearance of the facial skin. Epidermal and dermal atrophy result in wrinkling and thinning of the skin. Loss of skin elasticity, water content reduces and collagen synthesis declines, leading to a sagging of the skin. Degradation of skin quality and color. Wrinkling and a furrowing of the skin overlying the facial muscle. The surface of the skin shows various linear grooves, some of which are always present but deepen with age, and others that appear in later life. Skin contour lines are lines of division at junction of the various facial units, for example, the nasolabial groove. These tend to deepen and thus appear more prominent with age. Wrinkle lines or facial expression lines are caused by contraction of the underlying muscles are usually perpendicular to their axis of contraction. For example, horizontal forehead creases. With progressive loss of skin elasticity due to aging, these lines may become permanent. Dependency lines are produced by effect of gravity on loose skin or subcutaneous fatty tissue. For example, the crease formed anterior and inferior to jowls. Finally, relaxed skin tension lines, RSTLs, are those that follow the furrows formed when the skin is relaxed. For the most part, they correspond to wrinkle lines except on the lateral aspect of the nose, lateral aspect of orbit, and the chin. As such, relaxed skin tension lines may act as a guide in planning elective facial incisions. Closure of an incision in a straight line with its long axis parallel to the natural relaxed skin tension lines may permit the resultant scars to appear as natural skin crease. The next issue is fat. The processes occurring in adipose tissue that affect the appearance of facial skin with age are atrophy of the uniformly distributed subcutaneous fat and the localized excessive subcutaneous fat accumulation. Regarding muscle, the reduced tonicity of muscles of facial expression with age affects the appearance of the facial skin. Finally, the dental alveolus. With regard to the dental alveolus, alveolar bone resorption in edentulous patients has a significant effect on facial appearance. The alveolar bone supports the teeth, and tooth loss leads to progressive loss of alveolar bone. The mandible thereby rotates forward, increasing the chin prominence and reducing the lower anterior facial height, with the chin moving toward the nose. The loss of the dental alveolar support also results in bilabial retrusion and a dished-in appearance. In order to recognize the visible effects of aging, patients should be examined in natural head position in a brightly lighted in a bright room. There is progressive descent of the facial soft tissue with aging, which may lead to facial changes listed in the screen. Ptosis of the forehead may be accompanied by the horizontal forehead creases and vertical glabellar frown lines due to contraction of the corrugator muscles. Aging of the orbital region is characterized by excessive redundant skin in the eyelids, lowering the brow and orbital hooding, descent of the lateral canthus, and bulging of the orbital fat. The eyebrows sag to below the brow ridge. Midfacial soft tissue sag, resulting in exposure of the inferior orbital rim, deepening of the nasolabial folds, and jowl formation. The nasal tip descends, neck skin laxity, and excess leads to hanging skin folds, submental cervical fat accumulation, platysmal bending, and descent of the submandibular gland amplify the aged appearance of the neck region. If possible, in the final part of this class, we will discuss the aging in more detail. Moving on to the next big topic, the facial proportion. We will talk about first the vertical facial proportions. Classical, Renaissance, and neoclassical facial canons describe vertical proportional relationship with the vertical craniofacial bisection, vertical facial trisection, and the vertical craniofacial tetrasection. The head may be vertically divided into halves, with the eyes positioned on a line constructed halfway between the top of the head vertex and the inferior aspect of the chin, soft tissue menton. The lower facial third may be further subdivided into two equal parts, subnasal to labial inferius or sublabially, and labial inferius to menton. Vertical facial trisection, as known as the Voltuvian trisection. This proportional canon was described by the Roman architect Voltuvius and popularized by the Leonardo da Vinci. The face may be vertically divided into thirds, as upper facial third, tricyon, hairline to glabella, and middle facial third, glabella to subnasal, lower facial third, subnasal to soft tissue menton. It is notable that in patients with receding hairlines, tricyon may be located by instructing the patients to raise their eyebrows. The superior aspect of the contraction of the frontalis muscle indicates the position of tricyon. The lower facial third may be further subdivided into thirds. Upper lip is subnasal to stomion, lip embrasure, and lower lip is stomion to mentolabial sulcus. Finally, the chin is mentolabial sulcus to menton. The next is vertical craniofacial tetrasection. This proportional canon was described by the arboreted dura. The head may be vertically divided into quarters. The upper quarter is vertex to tricyon. Forehead is the tricyon to glabella. Upper head is glabella to subnasal. Lower face is subnasal to menton. Other proposal of the vertical facial proportion is artist's facial grid. A facial grid may be constructed using horizontal and vertical guidelines. The eyes sit on a line equidistant from vertex to menton. The grid is 5 eye widths wide and 7 eye widths in height. Now we are talking about the validity of the proportional canons. The canons described before were introduced by artists and sculptors as ideal of beauty, which were depicted in sculpture and painting. They continue to be useful guidelines, yet they are only guidelines. Farkas and colleagues tested the validity of these canons in a healthy population of young adult white Caucasians And his findings are summarized in the following. The total participants was 103. Regarding craniofacial bisection, among them only 10% fitted the canon, and 80% of the upper half was on average 12 mm taller, range from 2 to 29 mm, and 10% the lower half was on average 6 mm taller, range from 4 to 9 mm. In facial trisections, none of the subjects fitted the canon. In 100%, the lower anterior facial height, that is subnasal to menton, was on average 18 mm greater than the upper facial height, that is trichy to glabella. And 68%, the lower anterior facial height was on average 9 mm greater than the mid-facial height, that is glabella to subnasal. Regarding craniofacial tetrasections, none of the subjects fitted the canon. In 100%, the lower anterior facial height, that is subnasal to menton, was on average 19 mm greater than the upper head height, that is vertex to trichy. In 87%, the middle anterior facial height, glabella to subnasal, was on average 15 mm greater than the upper head height, that is vertex to trichy. Moving on to the cephalometric evaluation, to evaluate the proportional relationship of lower to the middle anterior facial height, horizontal lines are projected from the ANS, and menton onto the true vertical. The middle anterior facial height, MAFH, is measured from the projection of nasion to that of ANS. The lower anterior facial height, LFH, is measured from the projection of the ANS to that of menton. The proportional relationship of MAFH to LAFH is approximately 45 to 55%. This proportional relationship is more important than any absolute measurement. Regarding lower anterior facial proportion, Leonardo da Vinci subdivided the lower anterior facial height into thirds, with the upper lip height third and the lower lip and chin height as a two-thirds. This proportional relationship was subsequently confirmed in contemporary cephalometric studies by the Worms and colleagues and Ligon and Burston. Albrecht Dürer subdivided lower facial height into quarters, with the upper lip height quarter of the lower facial height. Schneiderman and colleagues found that LFH to be equal to the MFH in women. LAFH is greater than MAFH in men, mainly due to greater lower lip or chin height. The famous Farkas found upper lip height is around 31% of the LFH, and lower lip height is around 26% of LAFH. Finally, the chin height is around 43% of LAFH. There is a variation in the proportional canons and individual variability in the results of the modern studies. This again demonstrates that such relationships are useful first step in the clinical evaluation of the lower facial proportions, but only as guidelines. Each patient must be evaluated as an individual. When evaluating the vertical facial soft tissue proportions, it is useful to supplement the information from the proportional canons relationships with age, sex, and ethnicity-specific anthropometric norms with normal ranges of the variability for each vertical facial parameters. Using such normative values permits the derivation of the modern measured proportional ratio for specific patient group. Johnston and colleagues investigated the influence of the changing the lower face vertical proportion using facial profile silhouettes using attractiveness ratings scored by the laypeople. They found that the most attractive lower facial proportion was the Eastman norm. In other words, LAFH was 55% of the total anterior facial height measured from nasion to menton. This corresponds to a MAFH to LAFH ratio of 50 to 50 if facial height is measured from the glabella. Images with a reduced lower facial proportion were considered more attractive than corresponding images with an increased lower facial proportion. As a clinical implication, knowledge of vertical facial proportion is important in planning dentofacial surgery as well as in any prosthodontic treatment plan aimed at altering the occlusal vertical dimension. The vertical facial thirds should be approximately equal, although the lower facial third may be slightly greater than the middle third, particularly in males. The lower facial third may be further subdivided with the upper lip forming the upper thirds and the lower lip and chin forming the lower two thirds. An increased lower anterior facial height may be due to: first, the vertical maxillary excess (VME). Total vertical maxillary excess results from excessive inferior development of the maxilla. This is often accompanied by the excessive maxillary incisor exposure in repose and excessive gingival display at rest and on smiling, sometimes referred to as a gummy smile. Treatment, therefore, centers on superior repositioning of the maxilla. In certain cases of anterior vertical maxillary excess may be due to the excessive over-erupted maxillary incisors and canines. For example, Class 2 Division 1 or 2 malocclusions, in which case the treatment of choice will either be an anterior segmental impaction of maxilla or orthodontic intrusion of the maxillary incisors and associated gingiva. The gummy smile may also be due to excessive gingival tissue, in which case a gingivectomy to remove the excess gingival tissue and thereby move the gingival margin apically would be the treatment of choice. The second, the increased vertical chin height. The proportion of the lower two-thirds of the lower facial height, stomion to soft tissue menton, to lower facial third, subnasal to soft tissue menton, will be increased. Treatment will therefore center on vertical reduction genioplasty. The height of the face must be assessed bearing in mind the patient's standing height and stature as already described. The distance from the hairline trichin to the inferior aspect of the chin, soft tissue menton, is approximately 1/10 of standing height. The distance from the top of the head to soft tissue menton is approximately 1/8 standing height. Okay, moving on to the final part, the transverse facial proportions. The rule of fifths is a practical and convenient guideline used to analyze transverse facial proportional relationships. According to this rule, the ideal face may be transversely divided into 5 equal parts, each roughly equal to 1 eye widths. The central fifth of the face. The central fifth of the face is delineated by the medial canthi of the eyes. The ala base widths should be roughly equal to the intercanthal widths. This is important clinically as anterior and superior repositioning of the maxilla tends to increase the ala base widths. This may be partially counteracted by the placement of an ala cinch sutures at the time of the surgery to maintain the ala base widths. The inherent ethnic variation in ala base widths must be taken into account in diagnosis and treatment planning. An increased intercanthal distance may be due to telecanthus. This is a soft tissue measurement reflecting the increased distance between the medial canthi of the eyelid. It is a common finding in patients with Down syndromes. And orbital hypertelorism. It is the increased distance between the medial orbital walls reflecting on increased distance between the orbits greater than 2 standard deviation from the norm. It is a common finding in a number of craniofacial malformations such as Cruzen syndrome, Apert syndrome, and Pfeiffer syndrome. Move on to the next part, the medial fifth of the face. The medial flips of the face measured from the lateral to the medial canthi of the eyes. Mouth width at rest is approximately equal to the distance between the medial iris margins. Bigonal width is slightly greater than biocular width, distance from the left to the right lateral canthus. In other words, at a line from the lateral canthi of the eye, outer border of the medial flips of the face should be approximately coincident with the antagonal region. Bigonal width should be approximately 70 to 75 of bizygomatic widths. Increased bigonal widths may occur in patients with increased skeletal bigonal widths or in patients with masseter muscle hypertrophy. The gonal angle will be lateral to the outer border of the medial fifths of the face. Conversely, patients with reduced bigonal widths may require gonal angle implants to correct this proportion. Finally, the lateral fifths of the face. The lateral or outer fifth of the face is measured from the lateral canthus of eye to the helix of the ear. Prominent ears may have a significant effect on facial aesthetics, particularly if they cannot be camouflaged by altering the hairstyle. Correction of the laterally prominent ears may be undertaken by otoplasty. Okay, this is the end of this lecture. In the next time, we will discuss about the facial asymmetry. Thanks for watching. See you next week.